Good afternoon. I am so pleased to welcome everyone to our forum webinar today. My name is Colleen Berry, and I'm the chair of the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. And it's my great pleasure to co-chair the National Academy's Forum on Mental Health and Substance Use Disorders with Howard Goldman. This webinar is the second in a workshop series of 3 webinars hosted by our forum. The topic of the 3-part workshop is Mental Health and Substance Use Disorders in the Era of COVID-19, with a special focus on the impact of the pandemic on communities of color. Research has documented rapidly worsening mental health and substance use in the context of the pandemic and its disproportionate impact on the health, mental health, and well-being for communities of color. Before we begin today's webinar, let me first thank the sponsors of our forum, who are listed on this slide. Without the support of our sponsors, this work would not be possible. The mission of our forum is to provide a structured environment and a neutral venue to discuss data, policies, practices, and systems of care that affect people with mental health and substance use disorders in the United States. Our statement of task and the other information about the forum can be found on our website, which you can see in this link. Please note that a recording of the webinar and the meeting materials from today will be available on the event webpage. I also want to mention that at the end of each session today, there'll be time for questions for our presenters. And those of you attending the webinar who have questions should enter them into the Q&A box. I'm pleased to thank the Planning Committee for all of their work in putting today's session together. You can see their names listed on this slide. And it is my pleasure to introduce one of our 2 Planning Committee co-chairs, Deirdre Roche. Deirdre is a medical project officer with the National Institute on Alcohol Abuse and Alcoholism and their division on treatment and recovery research. Deirdre has been critical to our planning efforts, and I'm pleased now to be able to hand the baton over to her to get us started. Deirdre.
Well, thank you, Colleen, and thank you again to everyone in our audience for joining us today. As Colleen mentioned, due to the COVID pandemic, this workshop is being held over a series of 3 webinars. Part 1 was held on November 23rd, and a recording is now available at the following link to the National Academy's website. Today's webinar is the second in the series, and the third will take place on Monday, December 14th from 1 o'clock to 2:30 p.m. Eastern Time. The COVID-19 pandemic has created both short-term and long-term negative consequences for behavioral health outcomes. The pandemic has also created, revealed, and exacerbated long-standing racial and ethnic disparities in behavioral health care. The first webinar focused on how COVID-19 has revealed and exacerbated mental health and substance use disorders and highlighted the impact of the pandemic on communities of color. Today's webinar will focus on access to healthcare and delivery of services for people with mental health and substance use disorders in the era of COVID-19, especially among racial and ethnic groups that have been historically underserved. The third and final webinar will explore the mental health well-being of the healthcare workforce, with a particular focus on the impact of the pandemic on healthcare workers of color. Next slide, please. And now I'm pleased to introduce our first session of the afternoon, which will provide an overview of the impact of COVID-19 on access to care and treatment utilization for mental health and substance use disorders, with a focus on the US general population. Next slide, please. Our distinguished speakers are Dr. Brendan Saloner, Associate Professor at the Johns Hopkins Bloomberg School of Public Health, and Dr. Joe Parks, Medical Director for the National Council on Behavioral Health. In the interest of time, we refer you to the full bios for Drs. Saloner and Parks, which may be found in the briefing books located on the meeting webpage. Please join us in welcoming first Dr. Brendan Saloner.
I suspect you're on mute, Brendan.
No one can hear me. Okay, so I am delighted to get us started by talking about the impact of COVID-19 on access to care and treatment utilization for mental health and substance use disorder care during COVID-19. Next slide, please. So I want to start this off in a fairly stark way by just saying that COVID-19 poses what I think of as an existential threat to mental health and substance use disorder treatment for a few reasons. The first, and this became apparent to many of us early in the pandemic, is that treatment itself poses a huge risk of disease spread, especially if we think about congregate care settings such as methadone clinics, psychiatric hospitals, and mutual aid groups, oftentimes meeting in places where ventilation may be inadequate. Further, the populations that are at elevated risk of mental health and substance use disorder also have elevated risk of both contracting and dying from COVID-19 due to underlying comorbidities. Finally, the closure of clinics that was necessary to prevent spread, especially early in the pandemic, posed the challenge of fewer access points for patients and also for providers, a huge amount of lost revenue from decreased volume of care. Next slide, please. So posed with this massive threat, the federal government and state policy makers did respond in some important ways to these challenges. I think the most important of these responses was new provisions to facilitate the rapid take-up of telehealth. So we can see in particular some steps taken by the Substance Abuse and Mental Health Services Administration to provide new flexibility in the regulations around the provision of telehealth, especially around requirements related to 42 CFR Part 2 for substance use disorder treatment, and also provisions related to HIPAA compliance for the platforms that care is delivered on. And then the Medicare program stepping in and providing some new billing codes that allowed providers to gain reimbursement for services rendered by telehealth. For the two most regulated medications for opioid use disorder treatment, methadone and buprenorphine, similarly, SAMHSA and DEA enacted new provisions related to methadone and buprenorphine, allowing for take-home methadone in ways that was not available prior to the pandemic. So up to 28 days for the most stable patients, and allowing for induction of buprenorphine treatment through telehealth, which previously has not been allowed. The CARES Act passed by Congress in the spring was another important provision that provided a large amount of financial relief for providers and one-time grants from SAMHSA. I think the important caveat to keep in mind is that many of these regulations, while critically important, are also time limited, and they are tied to the declaration of a federal public health emergency, and they will be phased out without further action at the end of the emergency. Next slide, please. So I'm just going to quickly summarize some of the things that are known from the research so far. The first of these points is that mental health and substance use disorder treatment need has skyrocketed with the pandemic. We do know that there has been an unprecedented shift to telehealth for mental health and substance use disorder treatment. And we also have seen some very innovative models for providing care, especially as it relates to the provision of medications for opioid use disorder treatment. Finally, we know from at least a couple of studies that utilization of mental health and substance use disorder treatment initially plummeted, but actually have rebounded in important ways. And I'm going to just walk through each of these findings very briefly. Next slide, please. So on this issue of rising need for treatment, there's some important data points. The one that I'm showing here is from a study published by colleagues at the Johns Hopkins Bloomberg School of Public Health. The first author is Beth McGinty, and Colleen Berry is a co-author, in which the authors looked at a nationally representative panel in the spring of 2020 and compared it to 2018 data measuring validated indicator of psychiatric distress. And we can see that there was this stunning rise in the percentage of people endorsing symptoms of psychiatric distress and most concentrated among certain populations, especially Hispanic individuals and younger individuals. And this has been shown in other studies, this strong rise in depression, anxiety, and loneliness reported by individuals. Dr. McGinty has published in the last couple of weeks an update to this study showing that what had been documented in the spring was sustained in the last few months. So this is a persistent problem. Next slide, please. We also know that drug overdose, which was at a historic high in 2019, has continued to rise. So provisional data from the CDC show that in the early months of the pandemic, the overall rate of overdoses accelerated. I think that we're on pace to see the highest year of drug overdoses on record, and really some very frightening numbers in many states. So overall, we got a picture of just a population in great distress. Next slide, please. I do want to call attention to one important data project that's underway from the US Census Bureau, the PULSE program, which is a very rapid survey. These are data that were actually collected from 10/28 to 11/9, the 9th of November. So they come out with these data updates quite often and are measuring some indicators of mental health problems, and in this case, a need for counseling or therapy. And one thing that I just want to draw attention to is this important disparity across racial ethnic groups and income groups. And you really do see a gradient in the percentage of people reporting these problems. Next slide, please. So telehealth, what we know thus far is a big uptake and change across a variety of different kinds of mental health treatment. Psychologists reporting a 12-fold increase. In New York City's Health and Hospitals program, they published an early study showing that there was a rapid shift within their programs and that it actually led to some continuity of care for their populations, people showing up actually at higher rates for telehealth visits than face-to-face visits. So, and that, I think that was encouraging. Providers certainly reporting that telehealth has been popular for them, and it'll be interesting to see to what extent some of these changes will actually end up being permanent. And then SUD treatment providers also, while reporting some initial lost volume, actually regaining patients. And then just on the right of this slide, I just provided a screenshot of a story that ran in the New York Times last week about substance use treatment going online. Next slide, please. So I do want to really pick up on this point of medications for opioid use disorder. I think the key thing to note is that providers are not under any obligation to adopt these provisions, and states themselves are important kind of regulatory stopgaps between the federal framework and what might be available. So while there is the possibility of providing more take-home medication, I think the implementation on the ground is going to be quite different from provider to provider. I think there have been some really exciting and interesting innovations in treatment delivery. New York City initiated a program using courier services to deliver methadone to patients who had mobility restrictions, especially early in the pandemic. In Rhode Island, there was the creation of a telebridge clinic, so patients could actually call up a hotline and be connected on the phone to a provider who could start them with buprenorphine. In Los Angeles' Skid Row, a population that's predominantly homeless, a program created a telephone booth that actually allowed homeless individuals to do a video consultation and start their buprenorphine through that telephone booth. So I think these models certainly are not universal, but they do kind of offer a glimpse into what might be possible. Next slide, please. This is, I think, a very interesting study using electronic medical record data done by a team at University of Indiana. And one of the things that they showed looking across the variety of different kinds of healthcare that were being provided prior to the pandemic is that actually, if you look at mental health and behavioral health, you see this sharp decline early in the pandemic, but then a rapid rebounding. And this contrasts with things like checkup visits, which while they did rebound, they didn't rebound nearly in the fashion that behavioral health did. So it does kind of provide some important clues about how telehealth might have bridged the continuity of treatment. Next slide, please. So I just want to close out by highlighting what I see as some gaps in the research. And the gaps are really manifold because there's just so much that is not yet known, or at least not yet published on these topics. There's many, many commentaries out in the literature about what people are perceiving, kind of projecting, but hard evidence, I think, is still very lacking. One, I think, very important question is how many patients using services prior to the pandemic will be able to stay in these virtual care modes? I think, you know, a lot of us have gotten very used to life on Zoom. Certainly, it works for those of us that have good Wi-Fi and a certain level of literacy with online technologies. But for some patients, it could really spell a disconnection from care, and we don't totally understand that yet. I think very much tied in with the evidence about new need for treatment is how much of that, you know, what has been the magnitude of that in terms of the pandemic causing people with who may not have had clinically high levels of need to now be in need of treatment. And then what resources do we have to help those people get care? I think that's a very unknown question. And then quality of care. You know, we know that the care to some extent has been extended. I don't think we know really much at all about what the quality of care has been like for patients, whether this is patient-centered care, whether this is meeting high standards of evidence, and then also how that quality of care might vary across different patient populations, different demographic groups, different payers. So whether it's the same for privately insured versus Medicaid individuals. And then I think we need to think about this beyond this acute phase. We know that we're sort of in this pandemic posture for the duration now, and even with the vaccine coming to market, there's going to be a lot of long-term sequelae from the COVID-19 pandemic. So, you know, how will the full spectrum of needs be addressed going forward for people who are in acute crisis, for people who have newly developed anxiety disorders? I think it's important to note that with death rates rising and so much morbidity from COVID, there's going to be a lot of people with grief from loss. And that's a really important thing to think about, whether we have the capacity to help people who are grieving, and long-term needs related to mental health and addiction recovery. Next slide, please. So that really concludes my remarks, and I look forward to hearing from others and to getting your questions. Thank you so much.
Any questions for Brandon? Brandon, before I go ahead and present?
I think, Joe, we generally wait till after both of your presentations, and then I'll moderate the discussion. This is Howard.
Okay, well, I'm happy to go ahead, and it's a pleasure to follow Brandon. You'll find that my comments build on a number of his. I'm going to go over the increased demand, some of the impacts on providers, and then some of the changes with the increase in telemedicine. Go ahead, next slide, please. This is another one of those studies Brandon mentioned, showing basically the same trends he reported before. The CDC every 2 years does a whole nation survey of symptoms of anxiety and depression and suicidal ideation that are severe enough to impair functioning. And they had a baseline pre-COVID from the 2019 survey, and they ran a special sub-survey, representative sample again for comparison, in June of 2020, in the earlier phases of COVID, and really found these remarkable increases in anxiety and depression, severe enough to be impairing, going up by 300%, 400%, suicidal ideation, serious suicidal ideation going up about 180%, clearly increase in a need for treatment. Some sub-factors they looked at is symptoms related to trauma and stress disorder was up about 31%. Increased new starts or increased use of substances was about 13% increase. In terms of serious suicidal considerations, as Brandon reported, some very high rates among Hispanics, increased rates in African Americans, but it was the unpaid caregivers and the younger people that had the highest increases as subpopulations. This is more emotionally impactful on young adults, it appears, than on other age groups. Go ahead. So we also, at the National Council for Behavioral Health, we represent about 3,200 organizations delivering treatment for either mental illness or addiction. And we have been surveying our members periodically about the impact of the epidemic on their ability to deliver care. And in a survey, this is results of a survey in June again. Organizations at that time reported having lost almost a quarter of their revenue. They were down a quarter of revenue. At that point, 40% thought they could only survive 6 months. Only 32% got funding in the first round of relief. Behavioral health was largely left behind in the first round of relief. It has gone somewhat better in subsequent rounds, but it's been very confusing and somewhat difficult to access in a systematic way. 26% reported laying off employees, another 24% temporarily furloughed employees, and 43% told people they couldn't work as many hours, and enforced shorter days, shorter hours, don't work 1 day a week, that sort of thing. Over half had closed a program, and 65% reported having to reschedule, cancel, or turn away patients. In particular, the hardest hit organizations were the broad swath that are primarily paid under the fee-for-service payment methodologies. Fee-for-service was the least resilient form of funding, with grant-funded mental health services, prospective payment, like federally qualified health centers and certified community behavioral health centers, and capitated delivery systems being able to be financially resilient, and also having more latitude to shift services and change the way they deliver. This really revealed the weakness and the relative failure of our major payment methodology, fee-for-service, in responding to these kind of serious and unforeseen changes. Next slide. A number of our member associations at the state level have also been surveying their patients and asking, well, what are you looking for? What's different for you? And one of the outcomes I think we'll see from the epidemic going forward is it has changed permanently how patients want to get their care and the choices that I think they're going to expect to get. When asked the question and this is from Maryland, but we had several other associations with slightly different but similar trends in their patient preference surveys. But this question was, if you could get telehealth after the pandemic ends and you could be seen in person also, what would you want? Would you rather do telehealth or would you rather do in person? And in general, about 20% wanted to do telehealth all of the time. They don't want to come meet with us in person at all. 24% want to do it most of the time. So 44% of people, more often than not, would rather not see us in person. Another 26% would like to do a 50-50 mix. Only about 30% would really prefer to do face-to-face most or all the time. This is pretty reasonable. If you're getting a routine follow-up business and not particularly distressed, it's very rational to say, sure, let's do it by video. Let's not lose the transportation time. We heard they got comments like, it's hard to get to the office weekly. It takes me 2 hours out of my day getting there and back, or I have a traumatic brain injury. I can't remember appointments. Planning ahead to get to the office is hard. We found counterweighting the loss of funding and loss of staff and programming, people show up more on video. The do not show rates for appointments have plummeted. They are very small. When I see patients myself on a weekly basis, and it's rare for an appointment slot not to be filled. Many people are extremely grateful for this convenience, and particularly people of limited means who are dependent on Medicaid transportation or transportation from friends, or people in rural areas where it takes a substantial amount of time to travel to the clinic. This has opened up access, and our members at the National Council have reported getting some new people in due to the expanded availability of telehealth that would not otherwise have gotten into services at all. A particular note is that the telephonic services are much more accessible for people in rural areas with poor bandwidth and people of limited means that can't buy unlimited data plans than video services, and have performed surprisingly well and need to be a major consideration in terms of access and also in terms of patient preference. You know, what does the customer want? How would they prefer to receive their care? Next slide, please. When people were asked to identify the reasons they would rather have telehealth, why not come see us in person? 39% said transportation, 15% childcare. I got kids to take care of. 25% had physical restrictions. Half didn't want to give up the time. They have other things to do in life. Not surprisingly, 2/3 liked reducing their exposure to COVID, but even if that goes away, these other factors remain. They like the increased appointment flexibility, and some people just said I like it better. If you think about it, if you have agoraphobia or social phobia, well, of course you're going to want to do virtual services and probably telephone. Maybe you don't even want to be seen because that's part of your anxiety disorder. People working the night shift, it helps in my current job situation to access services without taking my day off. You think about it, you could take a long lunch break and get your appointment done. With everything that happens in my illness, it's just better to manage my stress and panic. I get more panic when I'm out. I'm more at ease in my home. It's been different to do the service also. You actually see into people's home if it's a video service, which gives different things to talk about. Go ahead. Now, on the downside, there have been people that have not done as well. We got reports, as you saw from Brandon, that there was early drops in substance use disorder. We continue to get reports that it is harder to engage people early in recovery, particularly in group treatment, which is particularly important early in recovery from substance use disorder, as opposed to in person. It appears to be easier to engage people with mental illnesses and keep them engaged than people with substance use disorder, with the exception of people with very prominent negative symptoms who respond in very few words with very little emotion. There's so little there to help you understand what they're trying to say, that additional loss of contact and information can really make a tipping point. So when asked, how connected do you feel to your therapist, case manager, your prescriber, whoever's providing the services, 13% actually felt better connected, 11% somewhat better, about half felt the same. And if you add up those not as well, as about 20%, about 1 in 5 felt the connection was not as good, but 75% thought it was as good as better virtually than in person. Well, that makes their preference. If I feel just as connected and I don't have to give up that time and expense of travel, why wouldn't I? That is a rational choice. Go ahead, please. So as Brandon mentioned, there's a number of temporary authorities, and this is the key issue here, is they are good for the duration of the public health emergency, and it's yet to be determined how soon they will end after the public health emergency ends. Will there be a phase down period, or will there be a sudden cutoff? Will it be one way for some authorities, another way for another authority? And there appears to be much more consensus on finding ways to continue increased access to video-based telehealth services than to telephonic-only telehealth services, which certainly has impact for the marginalized, disadvantaged population, people with social determinant problems, either due to their rural status, their low socioeconomic income, where they can't afford all those extra minutes. It is a disparities issue restricting the telephonic access going forward. Next slide, please. So looking to the future, at the National Council, we are educating our elected officials that behavioral health did not get the same level of support to get through the epidemic and has not had the same level of support historically to implement the infrastructure you need to do virtual care, whether it's video or EMRs. And we were requesting an additional $38.5 billion direct relief to behavioral health providers and organizations. We believe that some of the policies and regulations related to opiate medication needs to continue. also long-term, also the telephonic and the virtual authorities in general. We also think that we need to bear in mind how poorly fee-for-service has functioned and how little reserves behavioral health organizations had to deal with this economic stress compared to some general healthcare organizations, large hospital systems. They do not have the cash reserves to come up with these kind of stresses, and that's because behavioral health has been chronically underfunded. We are particularly impressed by the ability of prospective payment methodologies to buffer and to allow nimbleness and innovation to meet the demands of the things like the pandemic. And that would be expanding access to certified community behavioral health centers, initially in 8 states, now increased by 2 with Michigan and Kentucky, and a number of single agency demonstration states. But it really needs to be nationwide. It has worked marvelous for federally qualified health centers. It performed better in maintaining access and services during the epidemic, and we think it needs to be a key part of the future. Next slide. So here is where you can get a range of resources that we offer the general public and our members, and also results from our surveys of our members, giving information on how the impacts affected them and some information on what they've done to deal with it. And that ends my prepared comments.
Great, thanks a lot, Joe and Brendan. It's too bad you can't hear the thunderous applause following your presentations. That's one of the downsides of virtual presentations. But thank you very much. I also want to thank Joe for presenting the data from Maryland. That was my shop service to the single state agency to do that survey. We have a few questions, but we have plenty of time for people to add questions to the list. Actually, Brendan, I was imagining a millennial listening to your talk and saying, I think I can work out what Skid Row is, but what was a phone booth?
I'm almost a millennial. I think I am, and I remember phone booth.
You've got that down?
Yes, yeah,
All right.
I do.
I wonder about this, the telehealth. I wondered if each of you wanted to elaborate and express an opinion of your own about what you think we really should end up with as telehealth policies as we presume to come out of this pandemic, because it looks like we might actually come out of this pandemic. Brendan, you want to go first? Joe, you already hinted at it, Joe, but I'll give you a chance to elaborate a bit.
Yeah, I don't have a crystal ball. I think that there's a sense in which the pandemic is an accelerator of things that were already underway. So I think the writing has been on the wall that a lot of behavioral health services are moving toward telehealth provision, certainly. So I think that, you know, what we'll see coming out of this is some people who like it and want to stay in this, and some people who can't wait to get back and go back to face-to-face care. You know, the scenario that I think probably will work best for patients is a kind of all of the above. In an ideal world, people who want to stay virtual can stay virtual, and those who want to find meetings to go to or a clinic where they can see a clinician face-to-face should have that option. And with the needs that, you know, Dr. Parks was highlighting with some of the patients, this is just not a viable option for many folks. So I do worry about a scenario where it becomes all that's left. I think that would be truly damaging for patients and for the therapeutic relationship.
Yeah, thanks, Brendan. Joe, you want to elaborate a little bit? Do you think we'll crack the nut of being able to have telephone only and enhanced broadband so that we can do the video? And
I think that we will have some availability of telephone only, if nothing else, through Medicaid programs for seriously ill populations. But we really should have it available for commercial populations and for Medicare also, if that's what's needed. The question that we need to ask ourselves on the provider side before even going to the funders and policymakers is, how do we figure out who has done better with video, who has done about the same, and who has actually done worse? And then how do we balance choosing to offer what's more convenient at us for the provider versus what's more convenient in the patient's preference, what's really medically necessary. Because I would hate to see a future where we have big companies nationally that only do virtual, but if you get so sick you need to be seen person to person, then you get sent to a small local agency that's on a different, that has a whole different profit margin and difficulty surviving. There are potential problems with skimming high margin, easy to deliver care and segmenting the business. I think it's important to have organizations that can do the whole range of services. And I think it's important for organizations to be thoughtful about who they give which service to when, and not simply do it based on margin or their convenience, but to keep their eye on medical necessity, which means we're going to have to develop some kind of ability to track and assess in a clinic population who's doing better or worse by what mechanism and what duration of visit they need next. I've noticed for a number of my patients that are doing relatively well, when I see them by telephone now, they actually want less care. You know, they tell me when they're done. Everybody used to use their full allotted scheduled time up to the last minute. They would find something to talk about. And now if we've been fine with each other for years, they just need a real face time. Well, thank you, Dr. Parks, I'm done. That's all that I needed. And they decided to use just 8 or 10 minutes. Well, I think it's because they didn't have to pay the transportation costs and personal time and effort. But that's interesting. That's an increased efficiency. It's something to think about.
Yeah, I suppose we want to apply what we're learning about shared decision-making to this issue as well. Some people want A, some people want B, but we need to have the choices available to us as policies in order to do it. And I'm glad that you mentioned the concern about skimming off the easy problems and leaving the problems that really have to be dealt with in person. One of our questioners actually wondered how much the preference for telehealth was driven by fears of infection and having to go into a clinic, not just transportation. I suspect that that's part of the issue.
I'm sure that was some of it. From comments we've heard directly from consumers and patients, it certainly wasn't all of it. There are a number of patients that weren't particularly affected. I asked all my patients how they're doing with stress and isolation, and a good portion said, well, Dr. Parks, I've been self-isolating for 20 years now. Didn't you notice? I've not been going out. But Howard, I think this is part of what Maryland needs to ask your shop to help them with next. You did the great data on what people want. Now they need to have you do an analysis on who did better with which method so they can figure out how to target.
Yeah, that's a taller order. We'll have to speak to the powers that be about that. Brendan, you talked about the changes in medical assisted treatment also, those rules. Do you think those are changes that are here to stay?
I think there is a looming conflict that's going to happen around all things related to medications for opioid use disorder. So there's a lot of push within certainly some segments of the provider community to make these changes durable. And a lot of people felt like these flexibilities around take-home methadone should have been in place a long time ago. We've been out in the field talking to opioid treatment programs, doing a statewide survey in Pennsylvania, for example, and finding that there is a lot of receptivity and appreciation for how this has allowed them to tailor their model of delivery. I think that methadone treatment is very ripe for some disruptions in the care delivery model. Buprenorphine, similarly, the induction over telehealth seems like something that has the chance of sticking, but these are going to take acts of Congress, and I think that that's where it's just very unclear to me whether they will be able to get something through this Congress. So basically, it's going to come down to a big question of federal policy priority.
Thanks a lot, Brendan. Do either of you have any speculation on how this experience is going to affect our approach to infection control in the future? It occurs to me that we haven't thought a whole lot about it prior to this pandemic.
You know, one of the things that it certainly made our members aware of is that they hadn't been sufficiently connected with their local public health departments or their large medical systems in terms of their emergency response plans. Hospitals would close access on some of their behavioral health services, and the community providers didn't know that was part of their plan. perfectly reasonable if you're a big hospital and you need more beds to convert your psych beds to infection if you need to. But they simply were not in the loop. If nothing else, behavioral health needs to be much closer on the community side to the plans being made by public health departments and large health systems.
Yeah, I have to say, I feel a tremendous amount of anger about what I think will emerge as one of the real legacies of this time period, which is a huge amount of attention to, infection control in very highly skilled places, hospitals and the like, and just a huge amount of neglect for many places where very vulnerable people are getting care, nursing homes, prisons, jails, and also places where people are going for social services and mental health and substance use care. And I think that what we saw, especially early on, was just a huge amount of panic about the lack of supplies to keep health workers safe, especially health workers who are not in some of those high priority settings. So, it remains to be seen whether these lessons will be learned, but this is a real scandal, I think.
We had multiple reports of patients being referred from large hospital systems that were overwhelmed with treatment needs, but they did have PPE to put on the patient and on their staff, and insisting on discharging these patients to residential behavioral health treatment settings that didn't have masks for their staff or the patients, and they were happy to send the patient, but nobody could send them any PPE. And it just ain't right.
One of our questioners notes, the alcohol sales have gone through the roof and there's evidence of increase in alcohol use disorders. Do either of you want to comment on that, ways the system is prepared for it or not?
I'm interested to hear what Dr. Parks thinks. I don't think the system was ever prepared for it, and now I think this is one of those things that's flying under the radar. It's become a very normalized kind of thing to do in the pandemic, is to drink heavily, and I don't think that we've fully gotten our arms around what a big problem this is going to be in the next year or so.
It's wonderful that we're finally attending and opening up to access to opiate use disorders, but to some extent it's come at the expense of paying attention and tending to alcohol use disorders, which are indeed skyrocketing, and I would predict that they will be the big boogeyman on our radar screen within the next 5 years. Rates are way up, and we're not being thoughtful about it. I know one state closed all the liquor stores early in COVID so people wouldn't get infected. Well, of course, the people that were already dependent on alcohol all showed up in the ER and DTs and a withdrawal, and that was reversed, but there's something in between. And just as people need access to MAT, medication-assisted treatment for opiate disorders, there's horrible underutilization of medication-assisted treatment for alcohol use disorders that we do not pursue sufficiently.
Great. Do either of you want to talk about ways to assess the quality of the services being delivered by telehealth? I know, Joe, you suggested that our shop would do that for Maryland, but you have some idea about what kind of criteria you would use and how you think about it?
I know some of the early efforts are looking at the effect of impact on other services. So are we seeing increased or decreased emergency room usage, increased or decreased hospital? You can see the outcomes in people falling to higher level cares. A number of large payers are running those kind of analyses. A lot of the large payers are interested in continuing these services, but they understandably want to figure out what's a good quality versus a poor quality. National Council is part of a national coalition of payers and providers that's working on developing those kind of measures, but there's a lot of work to be done.
Great. Brendan, you could elaborate on that, or you could address a related question, which is that you proposed something on assessing whether will continue to be a need for a continuum of services.
Right.
So either of those two studies, I'd love to hear your thoughts about.
Yeah, well, I think that the first issue was nicely addressed by Dr. Parks. I think the only thing I'll add is that some of these things we'll never really get to the bottom of, I don't think. But we will have a chance to look in short order at things like whether continuity of pharmacotherapy for, let's say, depression or opioid use disorder fell off, and that's a kind of a measure of process of care. In terms of continuum, I think that we're going to have to think not only about the limited continuum of care that existed pre-pandemic, but about adding new forms of care. And I did want to really amplify this point I made about bereavement care, because I think we're just a nation that's going to be gripped by immense grief. I see the kind of the data, and it's clear that there's a lot of people who are experiencing loss of life in their families and people dying in just very traumatic ways. We really need to think about what kinds of care models are going to work for people who are grieving from the loss of loved ones.
Yeah, I think that's a really thoughtful comment, but history suggests that if there's a parallel with the pandemic of 1918, 1919, the country couldn't wait to stop thinking about it and fled right into the roaring 20s. I wouldn't have known much about it if two things hadn't happened. My great-grandparents both died. My grandfather's parents both died in the flu in 1918, 1919. And of course, studying the history of public health. But the public attitudes about it really reflected a wish to just flee and deny. But the amount of grief, whether it's expressed or not, is enormous.
Yeah, there's public grief and there's private grief, and I think that a lot of times the private grief has no way of expressing itself. So it'll be interesting to see whether we have a way as a nation of coming together and thinking about the loss that has come from this.
One of the biggest concerns we're seeing among our member organizations is the trauma that's been suffered by healthcare providers. Either the moral hazard, do I stop serving the people I'm caring for on the job to protect my family, or do I protect my family by staying home and give up on my patients? Or the increased demand and stress of changing all your programs and increasing your services. There's been a real increased focus on provider trauma. And I think we're going to see an increased focus on individual trauma. I think what's different a little now, Howard, than in 1918 is, remember, the incidence and personal experience of infectious disease death was much more common to that generation. We, before this, who knew anybody that died of infectious disease that wasn't 90 and it was a pneumonia in the hospital? We couldn't have named a neighbor that died unexpectedly of an infectious disease. It is outside our living memory to be used to that as a common social event.
I'm just older than you are, Joe. I remember the polio epidemics of the early 50s. But you're right, it's not part of our common experience. On the other hand, 650,000 people in a population of 1/3 the size died.
Yes.
It was still an enormous difference. Maybe not, perinatal infections were way more common, and childbirth infections.
And it's really unclear how much of the distress is economic as opposed to fear of infection. I mean, people have lost their livelihoods. Some is undoubtedly social, some is fear of infection, but some is, not having money in America drives people nuts.
Yeah, as difficult as the adjustment of the healthcare system has been, this pandemic revealed what a terrible social welfare system we're in. Listen, in your remarks, Joe, you talked about fee-for-service being a barrier and that it's not sustainable. You want to elaborate on that? And I'll let Brendan talk about it too, because I know it's something you're interested in. But why don't you start off, Jim?
Yeah, so the usual payment method is you only got paid for particular specific things if you saw a person face-to-face in a particular specific manner, and the epidemic disrupted almost all ability to do that. So for the first 2 months, there was no cash flow at all. And these were in agencies that carry a cash reserve of about 3 months, and there were any numbers saying, I'm not going to make my next payroll. And they're doing lines of credit. It was different for our members in states that are either still doing it, or have a capitation model, like in Michigan. It's different in states that were still relying significantly on grants, where agency basically gets a capitation that's a lump sum to the agency. Right. And it was very different for the certified community behavioral health centers to get a prospective payment that pays for the whole bundle of services.
Did you find that the amounts in the CCBHCs were satisfactory? I mean, it's better than fee for service and have no clients, but were the rates pretty good?
They were, especially once they said the non-face-to-face visits are fine. At that point, the rates became entirely sufficient. And there, of course, because of that funding mechanism, there was more ability to take staff that had been doing things that you can only do face-to-face and have them do other things that you can only do virtual. There was more nimble ability for the financing to support suddenly changed operational needs.
Great. Brendan, you want to riff
Well,
on
I
prospective
agree.
payment here?
Yeah, I agree with everything that was just said. I guess I would add that sometimes it's hard to know whether the sin is really a lack, whether it's really fundamentally about fee-for-service or a lack of a full continuum of billing codes within fee-for-service. I mean, you can do a lot to augment what fee-for-service does. One thing that I was really perplexed about, especially early in the pandemic, was why a lot of the tools of Medicaid programs that are in place to find high-risk individuals and to help them were not being more aggressively activated. So you can within our current system do a lot more prospective things to find people who need help and get them the help that they need. But instead, we sort of had a very passive approach and let this disease wash over people whose deaths could have been prevented. And again, I think that will emerge as one of the real dark stains of this whole situation, is the lack of proactive response to what was easily seen to be a group of people who needed help and didn't get it.
Great. Thanks. Are there any things that either of the two of you want to say before we close out this session?
I don't think so. We've hit the major points. I want to thank you for gathering the information on the patient preferences in Maryland. That was...
Yeah, well, that's my staff, Dicey Bolt, Karen McNamara. I mean, they did a great job. And we're in the process of redoing it, Jeff Ott. Anyway, Brendan, you have anything else you want to?
I don't. I just want to thank you all for doing this. This is a great event.
Yeah.
I have a personal comment I want to make, because you started off talking about the increased rates of depression, anxiety, and my own experience is that first off, the experience has been one of fear. It's a rational response, but it led to changed behaviors. But as it happened, in spite of being very, very careful, I developed COVID about 3 weeks ago. I had a very mild case. But one of the predominant symptoms, especially by day 7 or 8, was anxiety.
Mm-hmm.
And anxiety about the unknown longer-term consequences of this infection really got to me. I can say that I'm doing fine now. I'm out of my isolation and my wife's quarantine. We're fine. But it's a warning to people that even being very, very careful, you can still get infected.
Well, and if you think about it, it is almost perfectly designed to create PTSD, because you have a serious threat that you can't do much about, that you must bear helplessly over time. You get your initial symptoms, and then you have to sit and wonder till around day 5, am I going to be one of the portion that gets horribly severely ill, or am I just going to get better? And you have this 5-day period of helplessly being under threat.
Yeah, I really enjoyed chairing a session the last 2 days where the main focus was people coming in talking about the long-term sequelae to prepare Social Security. Anyway, you guys were terrific. Thanks very much for agreeing to take the time out of your schedules, and I'll turn it over to Deidre.
Well, thank you, Howard, and many, many thanks again to our speakers, Drs. Brendan Salona and Joe Parks, for very informative and thought-provoking presentations and a very engaging discussion. I'm only sorry that we don't have more time. The second half of our program will address access to care and treatment utilization for mental health and substance use disorders during COVID-19, with a focus on the disproportionate impact on communities of color. Our distinguished speakers for this panel, next slide please, are Dr. Ruth Shim, Luke and Grace Kim, Professor in Cultural Psychiatry in the Department of Psychiatry and Behavioral Sciences at the University of California, Davis, Dr. Margarita Alegria, a professor in the Department of Psychiatry at Harvard Medical School and chief of Disparities Research at Massachusetts General Hospital, and Dr. Howard Stevenson, Constance Clayton Professor of Urban Education in the Human Development and Quantitative Methods Division, Professor of Africana Studies, Director of the Racial Empowerment Collaborative, and Director of Forward Promise at the University of Pennsylvania. Again, full bios for Drs. Shim, Alegria, and Stevenson may be found in the briefing books located on the meeting webpage. Please join me in welcoming first Dr. Ruth Shim.
Thank you so much, Dr. Roach. It's really great to be here with you all to talk about this important topic. And because we have such limited time, I'm going to just launch right in. So next slide, please. So when I've been thinking about why we have disparities in mental health, in my training at the earliest stages, I thought about this in the ways that I was taught through reports like Unequal Treatment and other groundbreaking work that came out of the National Academies. We talked about how patient level, provider level, and systems level factors cause differences in outcomes that we see in mental health. And despite the fact that these systems level factors are really important and really critical, I think that there has oftentimes been a thought that it is hard to tackle these types of issues. And so what I've noticed has been happening is when we think about how do we address differences in outcomes in mental health, many of the time we focus on patient level factors and we focus on provider level factors. And so we might spend a lot of time talking about individual patients, individual clients accessing treatment, and maybe having fear or mistrust of the system, maybe lacking insight into what is their mental health or substance use problems or needs, maybe highlighting that there might be cultural differences in certain communities of color that changes or affects treatment-seeking behaviors. And we may even talk about the intersection of people of color having additional stigma or additional thoughts about the intersection of substance use disorders and mental health problems, as well as identity differences in identity. Or we might talk about provider level factors and say that that certain providers don't have the appropriate cultural competence, that they are harboring implicit bias, that they have language barriers, or there are geographic differences. And again, I find that the emphasis is often on these patient and provider level factors. But I will say that in the work that I've been doing over the last several years, I'm starting to understand that the patient level and the provider level, which we tend to focus on, is not really what's driving the differences in outcomes that we see in mental health. Actually, these systems level factors, these structural level factors, including the cost of care, societal stigma, fragmentation of services, and really what I think are the most important things, the social determinants of health and structural racism and discrimination, are really the things that are driving these inequities. And I will also point out that the structural racism and discrimination then leads to a lack of a diverse workforce, which we sometimes think of as a provider level factor, and then that also drives these mental health disparities. But before we move on, I think it's really important to define mental health disparities and mental health inequities. So next slide, please. So health disparities are differences in health status among different segments of the population, including differences that occur by gender, race, or ethnicity, education or income, disability, or where you live. Next slide, please. Health inequities, however, are disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. And I just want to pause here and note the difference between these two definitions, because we talk a lot about disparities, and especially in the United States, we focus on disparities and we talk about how there are differences in health outcomes, and there may be differences in access to care, which is what we're talking about among certain populations. For instance, certain communities of color compared to white populations. But in fact, when we think about health inequities, and when we think about mental health and substance use disorders specifically, we are really actually talking about systemic, avoidable, and unjust social and economic policies and practices that drive those differences in health outcomes. So it's not just an intrinsic or an internal difference that you find in certain populations or certain groups. You're actually seeing a deep creation of these inequities from the policies and practices that we promote in our society. Next slide, please. And to help kind of solidify this point, I'd like to present this conceptualization created by myself and Michael Compton around the social determinants of mental health. And it's a pretty busy slide, but it's actually pretty basic, so I'll just go through it. So at the top, you see adverse mental health outcomes, and you also see mental health inequities as we've described them. And right under that, kind of leading to those adverse mental health outcomes and mental health inequities, you see a number of risk factors. That includes reduced options and poor choices, behavioral risk factors, physiological stress responses, and psychological stress. And I would just say that those risk factors, we all know that risk factors are the things we like to identify when we're trying to address mental health and substance use disorders. But what I'm starting to understand is that if you're intervening at the level of the risk factor, you're intervening too late. Because the disease has already kind of set in, has already done its damage by the time that the risk factor is working. Even though the risk factor precedes the disease and increases the likelihood of the development of the disease, actually the risk factor is not what Michael Marmot calls the causes of the causes, or what Lincoln Phelan called the fundamental causes of disease. So to move more upstream, you then get to the social determinants of health, and in this case, the social determinants of mental health. And that includes things like adverse early life experiences, discrimination, low education, unemployment, homelessness, and food insecurity, and adverse features of the built environment or neighborhood disorder. What I'm recently, my work has helped me to understand even further and with more concern is that if you're intervening at the level of the social determinant, you're still intervening too late, because the contextual factors that have created those social determinants started far before that. And so we actually have to intervene even further upstream. And what's driving the development of the social determinants of mental health is actually unfair and unjust distribution of opportunity, or what we might call social injustice. And what social injustice is being driven by are social norms, or the general ideas that we feel about people, our value structure, and why we decide that certain people are worthy of advantages and benefits in our society, and why certain people in certain populations are not worthy of those same advantages and benefits. And then based on those ideas or values that we place on certain populations, we pass laws and policies as a society to confirm that. And that leads to the unfair and unjust distribution of opportunity that creates the social determinants of health. And what's interesting about this is, for example, if we were just to talk about this as it relates to substance use disorders, for example. So in general, we have a social norm in our society in which we believe that substance use disorders, that people that use substances or people who have a problem with substances are somehow morally bankrupt, or maybe somehow their value system or their structure is less than other people. And we can even go even more specific into this depending on the type of drug that you're using. For instance, we have very different ideas about what it means to be a crack cocaine user than it does to be what it means to be an opioid user, a prescription opioid user in particular. And so we create these values and structures, and we determine who is worthy based on that social norm. As a result, we pass laws. And so what you see is that you see the criminalization of certain substances. You see crack cocaine use leading to mass incarceration, whereas opioid use disorder leads to public health interventions. So those laws that we create based on our social norms and our value system lead to this unfair and unjust distribution of opportunity that then leads to all of these social determinants of health, including mass incarceration, the war on drugs, and all of these things that you see that lead to then these differences in outcomes that we see in society. Next slide, please. So I just want to take a quick moment to come up with, to highlight a couple of important definitions that will help us when we're thinking about why these inequities exist and why they persist. So the first is this concept of essentialism. It is the belief that there are distinct and unchanging and natural characteristics that define groups and facilitate their categorization. We try to put people into categories. I think that's important. It helps when we're doing things like public health. It helps when we're facilitating organizing populations. But there is a risk in categorizing people and believing that these are immutable groups. And in fact, we know that, especially thinking about racial and ethnic groups and communities of color, that essentialism does not exist, that you cannot put people into easy categories that helps to explain things and facilitate our understanding of these groups. Another important concept is erasure of context. This is a failure to consider the socio-historical context when seeking to understand why inequities exist. I will talk about that a little bit more. Biological determinism is the false belief that racial groups are biologically and genetically different. And then cultural determinism is the false belief that these differences that we see are purely the result of cultural factors. And so it's when we're not focusing on structural factors and kind of over relying on cultural differences to explain outcome differences. So both biological and cultural determinism are often held up as the reasons for why we have differences in outcomes, when in fact that's not the case. Next slide, please. So I want to re-present some data that was mentioned first in the previous session by Dr. Smedley. And this is SAMHSA data that talks about access to care for people of color, and particularly Black and Latinx adults. And so in 2018, this SAMHSA data showed that about 69 and 67% of Black and Latinx adults with any mental illness received no treatment. And about 42 and 44% of Black and Latinx adults with serious mental illness received no treatment. And Dr. Salinger kind of added to this data around people who need therapy and don't receive or don't access that therapy. Next slide, please. The other portion of this data that is particularly disturbing is that 89% of Latinx adults with substance use disorders reported receiving no treatment, and 88% of Black adults with substance use disorders reported receiving no treatment, which is an overwhelming majority of people who need treatment for substance use disorders that are not getting that treatment. Next slide, please. What's interesting about that is that we have a lot of interpretations about why it is that people aren't getting the care that they need. And a lot of times we think, oh, this is stigma. We default to these patient level factors. We default to these internal and these individual level explanations for things. And we think about things and we'll say, oh, it must be a minimization of symptoms. It must be stigma. It must be cultural differences between these populations. But actually in this data, what we saw is that cost is the most commonly cited reason that people do not seek that care, that people don't get that substance use disorder treatment, and people don't get the mental health treatment that they need or require. And that really fundamentally comes down to the ways that we have designed our healthcare system, the ways we've defined and designed our mental health care system. And the fact that we've split off our mental health care system and created this completely separate process and by which we manage and treat mental health disorders. Again, the result of the values that we've placed on mental health and substance use disorders, and then the laws and the policies that we've created to manage it. We have an additional problem that mental health providers aren't really, especially psychiatrists, are not often going into public sector practice. They're often opening cash only practices, which is leading to a problem with access. Next slide, please. So this is data from the CDC. You can see that the cases and the hospitalization and death rate by race and ethnicity. This is an important slide, but it also, this infographic is a little bit concerning because it emphasizes, I think, sometimes the wrong things when we think about why we have these differences in outcomes, why we have inequities in COVID rates and cases and death. If you notice, there's an emphasis on the factors that increase community spread. Again, focusing on individual causes of the differences in hospitalization and death rates. And then there's a mention at the bottom of this infographic about that race and ethnicity being risk markers for other underlying conditions. But it doesn't really highlight the fact that socioeconomic status, access to mental health and mental health care, increased exposure from frontline workers who are more often people of color than they are white people, that those are really the things that are driving these differences. Instead, race is kind of presented in comparison in rate ratios compared to white and non-Hispanic patients. And we also see that this comparison is not entirely clear in giving us the full complement of the data, because we see, for instance, in Asian and non-Hispanic persons, there's no increase in death, but we really haven't looked at subpopulations where we see huge differences there. So next slide, please. So it's better to present this data in a different format or a different way. And this is data from the COVID tracking project, which shows that the death and case rates are proportionately or disproportionately high. And as you can see, that dotted line at the 100% is where the share of the proportion of the population is. And for both Black, Latinx, and Indigenous populations, you see that the death and case rates are above their proportion for the population, while white rates have stayed disproportionately low. Next slide, please. And so to kind of wrap up what we're talking about here, this was a study that was put out by Ettman and colleagues looking at depression symptoms in US adults before and during the COVID pandemic, and a commentary that I provided related to this particular study. What we saw is that the rise in depression rates in the COVID pandemic were attributable to multiple social determinants of mental health, including unemployment, food insecurity, poverty, discrimination, adverse early life experiences, and poor access to healthcare. And I really want to highlight what Dr. Saloner mentioned before around the adverse early life experiences, the bereavement, the death, and the differences in death among communities of color. Because you see those disproportional rates of death in those populations, what it means is that those populations are much more likely to know people, to have people in their families, to have close family members that died from COVID. That is not necessarily the case for the majority of the white population in this country. It may be more anecdotal, but may not be a close or personal relative or person who died from this, from the pandemic. And therefore, what you see is that there are differential rates of grieving. There are more families touched by this, more younger people, which Dr. Alegria will discuss. And so as we can think about this, we need to think about how our interventions are going to focus on addressing the social determinants of mental health in order to alleviate this problem going forward. So I will stop there and pass it along to Dr. Alegria.
So thank you very much, Ruth, and it's a privilege to be here as part of this group. It's such a great opportunity. Let me go very quickly through my slides because I'm hoping to make a linkage to several big ideas. Next. No conflicts to disclose. Next. Let me start by saying that I'm hoping that in this presentation, which is going to be very brief, I can talk about the ecology of inequality that leads to so many negative outcomes for youth and emerging adults of color, who at the same time leads to increases in behavioral health that then when they seek treatment, they find that there's huge treatment gaps to access care, and that in itself goes again and exacerbates the ecology of inequality. So my first message for today is the importance of ensuring access to behavioral services for youth and emerging adults of color. And I hope to convey why this is so important. Next slide. First, I mean, we know and we have seen from some data on adults that low-income parents are facing huge economic instability due to COVID, but that this hardship is really transcending itself into development, PTSD, and hindering child development. I think one of the things that Dr. Parks talked about is PTSD, but actually the PTSD, we're worried we're gonna see not only in the adults, but in the children. There's a lot of loss of community connections that the children have endured, particularly the support that they receive in schools, and the social isolation that now they confront that makes it so hard for these children, particular families of color. Next. We also see that COVID has been financially devastating for communities of color. Especially, I'm going to use Latinx families and other families of color. But if you look at Kaiser Permanente survey, 42% of Latino families indicated that they had really gone through their savings to pay for basic living needs. And this was early in the pandemic. This has been compounded with a lot of anti-immigration legislation, including public charge, which has made an environment of fear, uncertainty, and great threat that also takes a toll on people's mental health. In fact, COVID-related fear and anxiety and depression symptoms have been shown to be higher among Latinos and Asians, and especially immigrants who have small children. Part of this, it's hypothesized that has to do with the fear that they are gonna be separated if they have COVID, and then there's gonna be a separation with their children. Next. The other thing that we see is worse mental health outcomes, increases in substance use, and elevated suicidal ideation, according to CDC. And this, people have hypothesized that has to do with what Ruth was talking about, food insecurity, increases in family conflict, and then the severe poverty that these families are experiencing. At the same time, as I said before, these are the families that confront huge obstacles to behavioral health resources, while they also are home confined, and the longer that home confinement is, we know that it has a bigger impact on mental health services needs. Next. Yeah. One of the things I want to emphasize that's different than what has been presented before is the huge amount of children mental health access that goes through emergency departments as the first point of contact. In compared to 2019, for example, the proportion of mental health related visits for children had increased already by 24% for children 15 to 11, and 31% for children 12 to 17. And this is in comparison to 2019, this is in 2020. You can see here that there's a big increase in emergency visits for mental health reasons. Pre-COVID, we already know that the biggest groups, the highest number of visits rates were among Black children, followed by Latino children who experienced the biggest increases as compared to white children. This suggests the importance of expanding mental health beyond what can be accessed in a one visit in an emergency care department. Next. Data from the CDC is showing us another grim statistic, which is emerging adults, those that are 18 to 29, reporting the highest rates of depression and anxiety. But worse than anything is that it's showing that that's steadily on the rise. For example, for 18 to 29-year-olds, you can see from April to May, 46.8% rates of depression and anxiety symptoms, but that went all the way in October to November of this year to 58.7. So across all ages and time periods, we see Blacks and Latinos reporting the higher rates of symptoms of anxiety and depressive disorders than their white counterparts. And this is the emerging adults. Yet one of the things I want to emphasize is in work that we have seen, it's in emerging adults where we see the biggest gaps of mental health care, partly because the children get some care or used to get some care in schools. But once you move out of the school system, there's really tremendous gaps for emerging adults. Next. We also see that part of the problem might be a disproportionate reliance on Medicaid for Black children and emerging adults. Although Black children represent 14% of the child population in the US, we know that they represent 20.8% of the children in Medicaid. So they're almost twice as likely to be covered under Medicaid. And we know, however, that there's low Medicaid reimbursement rates that create a very hard circumstance for safety net providers to operate. In fact, this was covered also by Dr. Park. Some of the behavioral health providers had seen a 50% loss of monthly revenues. And so it is very hard to offer services without a true reimbursement. Among Medicaid and CHIP beneficiaries ages 18 and under, during March to May 20, there were 44% fewer outpatient mental health services. This is even accounting for other covariates, an increase in telehealth for that same period on 2019. So not everyone is getting better access to care during the pandemic. Next. I think my second message is the importance of prevention and community engagement as key to really try to resolve or mitigate the disparities gaps in access. Next. We know that child poverty has been increasing with the pandemic, but I do want to emphasize that it started, the baseline for children of color was even worse, with 31% of Black children being in poverty and 30% of American children being in poverty and 23% of Latino children being in poverty. So the baseline at which this family start and this children start is already in a very vulnerable position. Next. So we know that with COVID, even with the reliefs of the CARE Act, it only reduced poverty just for a while, but then the levels have since increased. For example, from February to September 2020, the monthly poverty rate went from 15% to 16.7%. And the rates were highest among Black and Hispanic children. So there's a huge need to expand income support for these families if we're gonna try to mitigate child poverty. Next. I also wanna say that this was even exacerbated more by the low-income families being hit hardest due to suspension of school-provided meals and the high rates of unemployment that they confronted. Although the EBT cards were reauthorized, and this is the electronic benefit transfers, were reauthorized to operate during the school year 2021, a lot of official guidance to implement plans at the state level didn't happen until November. So a lot of those children really were suffering food insecurity without no mitigation. Next. I want to show you the food insecurity that these kids suffer. And I want to show first the Black children are the blue line on top, 41%. The yellow line are Hispanic Latino children with 36.9%. And the last line, the dark blue line, white children, 23%. What I want to emphasize about this is food insecurity is one of the flags with work by Katie McLaughlin showing how it's so related to having mental health problems. all types of mental health problems. It shows that it is a risk factor for mental health problems. Next. Also want to show you that where children live, especially children of color and emerging adults with extreme exposure to violence, that work by Sharkey and Sampson looking at neighborhoods with high levels of violence, and this is before the pandemic, but it does show that where people live is so related to self-regulatory behavior, to cognitive functioning and academic performance. And over extended periods when youth confront living in intensely violent neighborhoods, it affects child health, it affects brain development, it affects cognitive skill development and academic performance, which is the center of youth lives. And as a result, it really has negative consequences on young people. Next. So the result of this is that we see a lot of emotional and behavioral problems that then lead to discipline referrals, that lead to suspensions and dropout. Among youth 16 to 24, Black and Hispanic youth were more likely than whites or Asians to have dropped out of high school. And this is partly attributed to financial need, but it's also attributed to so many other social injustices that affect academic problems and as a result, dropout. Next. I want to talk about how also we see stressors being a trigger for suicide attempts in a time of COVID. There is an expectation that we will see increases in suicide rates as families and as the result of COVID due to all the debt, all the economic stress, and especially the disproportionality of this overwhelming debt affecting low income and vulnerable communities. Next. I want to say that this is something to be very worried about because already we are seeing the rate of Black youth suicide on the rise. This is even before the pandemic, but we are worried that this is going to skyrocket even more. We know that Black youth under 13 are more than twice as likely to die by suicide than their white counterparts, and that this rate is increasing at a faster rate than any other racial ethnic group. And this was not the case before. Next. And even though there has been a lot of discussion by Brendan, by Dr. Parks about telehealth services as being the panacea for getting services to these communities, we already know that there's a digital device that's creating that many of these families don't really have the technology or have services that have the bandwidth to have good mental health care services during the COVID pandemic. For example, Figueroa and Aguilera talk about how data from primary care clinics show that these video consultations, although they have increased by 80%, minority groups represent a much smaller proportion of these visits. Next. I also want to emphasize the school-based services because a lot of the children's care comes through really public health insurance and mental health services that are exclusively received from schools. Yet school closures are giving no opening for mental health service for many of these kids. So we need to have a bridge to youth that traditional were served by the schools so that they can contact providers in community health resources that might actually serve as behavioral health counselors or providers. Next. Also want to talk about the importance that there's no magic bullet to really deal with the mental health cycle that I'm talking about. The cycle that goes from the ecology of inequality to negative outcomes for youth and emerging adults of color that leads to increasing behavioral health problems, and then the disparities in access to care. I think there's several things that we will need to do. One are multi-level interventions that really work with communities of color, where we can really link all of this social determinants and public health resources to the communities and offer stronger ties that can help in well-being. We also are going to need to look at the environment, how our environments, the confinement, the actual supervision that is being done with kids by cameras, where kids cannot actually, in some of our poor communities, cannot socialize because of fear that they're going to be captured in cameras and actually have problems. We need to build more parks, more green spaces that allow them to socialize in safe environments. And then integrating social services. I think we cannot think about behavioral health as separate from all the other needs that these children have to cope with the stress. Next. I think my last message is the importance of investing in behavioral health care, because the investment will be long lasting and probably prove being central for the recovery of our nation. Next. Let me show you how the demographics of our country are so dramatically changing. As you can see here, this is 2016 compared to 2060. And this is for children, the composition of children under the age of 18. And this is the racial and ethnic composition. And you can see there that although in 2016, it was close to 50-50, now by 2060, the rate of white children will be 36.4%, and then the rest would be children of color. And you can see there that the rates of Hispanic, Black, and all other mixed races will be dramatically high. Next. Therefore, the minority youth that we invest today will be the parents of the youth of tomorrow. And this minority youth are so central in the nation's working age population. They will be responsible for the economic growth and the taxable population. So investing in them is an investment in the future. Aging white majority populations are going to be dependent on this demographic. And programs such as Medicare and Social Security will be paid by these young and emerging adults. So continued investment in diverse youth is something that we should be doing from the get-go. Next. I have some policy recommendations based on a lot of work we have been doing. I want to talk about a few of them in my ending comments. I think we are gonna, like Ruth was mentioning, we're gonna have to expand and invest more in social service to make sure that everyone gets social determinants of health as a component of their mental health care. It's rare that we see someone that comes only for mental health care in communities of color. They have so many other struggling demands that they're trying to deal with. We're also gonna have to think about federal regulations to fund novel behavioral health treatment programs. I think we've seen with COVID that this is an incredible opportunity for being creative and trying new things in the next 5 years, particularly in communities of color that have high exposure to COVID and high unemployment rates. I think the other thing that we'll need to do is bringing community services to youth. I think it's not only limited to the schools. We need to go to youth organizations and other social services that can allow us to give care to kids beyond school settings or community colleges. And then I think the importance of integrated mental health, addiction, and infectious disease in an overall package that is really given by public health infrastructures free of charge and eligibility requirements for children and emerging adults. So we have a chance to really get this very early on and provide better opportunities for the future. At the end, we need to accelerate mental health and addiction workforce, because right now, like Ruth was mentioning, we need a lot of training and education of professionals to expand the pathways to access care. And this might be through paraprofessionals and peer counselors that can implement the services and be actually accountable through performance measurement. Thank you very much. I look forward to questions. Now, I think it's Dr. Stevenson.
Dr. Stevenson, if you're speaking, you're still on mute.
Can you hear me now?
Yes, we can.
Okay. So I'm going to try also to be brief and just basically talk about my background primarily with regard to this work has been around evidence-based culturally responsive interventions, and particularly trying to create measures and interventions that capture the racialized experiences of Black and Brown folks, where racism and discriminatory racial encounters undermine health, understanding how oppression harms, and in particular, understanding how families of color use racial socialization to protect and affirm youth. And I appreciate what my colleagues, Dr. Shim, Dr. Legre have mentioned, particularly Dr. Shim, around these larger factors that are unaccounted for. And then recently, we've been focusing on racial literacy as a way to be more specific in an evidence-based model around skills, and eventually to demonstrate, are people competent or not at actually delivering culturally relevant services. But recently, in the process of the last 5 years, I've been working as part of a philanthropic effort through the Robert Wood Johnson Foundation around servicing communities of color, particularly for the health of boys and young men of color. And in this sort of process with Dr. Rhonda Bryant, my co-director, I'm going to share a little bit about our frame and also our communication to leaders in the community about how they saw COVID-19 affecting their community. Part of our frame was around this notion of healthy villages. We knew it takes a village to raise a child, but what does it take to create a healthy village and community that help young boys and young men of color heal, grow, and thrive? And we picked out the notion of dehumanization, which matches what Dr. Shim was recommending. If you take a larger frame about how these things start, part of that notion is not only in criminal justice systems, but in education, health, and work systems. You still find a creation of narratives that problematize Black and Brown people. And in some respects, I would argue that not only does this threaten the health of the families and the villages, but it should be known that many of the folks that we work with, we target grassroots community efforts who have some experience in culturally responsive intervention to consider how they think about historical trauma, and particularly racism and colonialism as a form of dehumanization, which we do know preceded and in many very blatant ways accompanied COVID-19 over the last many months. So we think about racialized trauma and colonization trauma as following SAMHSA's guidelines around trauma as historical, cultural, and spiritual, social, emotional, and physical. And we also, the great amount of research is looking more about how racial stress, uniquely different from generalized notions of stress, impact a host of physiological and health outcomes. Dr. David Williams, obviously a fantastic researcher in this regard, that we moved as a philanthropic group to thinking about healing-centered engagement beyond trauma-informed care, where there's much more attention to the racially specific experiences of the folks that we're working with. And that work is focusing on what's right with you, not just what's wrong with you or what has just happened to you. But it also wants to appreciate the notion that historical colonization and racial trauma cannot be overlooked, not only in the interventions, but also in the measurement. And it questions the notion of resilience as something that's more like a stop on the journey as opposed to a destination, where we think about collective as opposed to individual foci. And the question that's raised, which I think Dr. Shin pointed to very well, is that, if the water is polluted, why are we blaming the fish? So in our work, we interviewed our grantees, over 30 grantees, just about their experiences during the pandemic. And we have a report on this. If you go to www.forwardpromise.org, we'll get to this. And just a comment from James Baldwin: history, as nearly no one seems to know, is not merely something to be read, and it does not refer merely or even principally to the past. On the contrary, the great force of history comes from the fact that we carry it within us. And I think one missing element of whether we're thinking about research or intervention during this crisis is how much, or what our grantees told us, how much they think of history as part of the trauma as well as the healing. And in a summary of that work, we got from them a notion that that the services that are provided to them are ignorant of that historical trauma, right? That there are ways in which we do identify disparities that have been around for a century or more and still don't have plans on what to do for future work. The exacerbation by COVID-19 of this kind of trauma, where mental health outcomes, as has already been mentioned by my colleagues, the basic food and cash assistance are key to understanding, whereas other models don't think about those very basic necessities. The essential workers to survive is to get sick, and then the blocked access to cultural and indigenous healing practices, which some consider medicine. And I just want to share one particular commentary from one of our grantees. His name is Ampeo Duta Flying Earth. And I want you to hear his thinking on this issue when I asked him these questions. Okay.
Takes me two different ways, or maybe not different, but it makes me think of two things. One is it has made us take a step back in terms of what are those processes and protocols and traditions in the community that had to be put on pause. So actually, a lot of our Pueblo relatives here in the state have had to pause on their dances and their feasts.
And Ampeo Duta Flying Earth is a quite famous leader in not only the indigenous community in New Mexico, but he's the director of the Native American Community Academy. So I just wanted to give you that background.
Of which are celebrating, deities and saints in their belief. And we're having to think, if I think about back home and our network schools in South Dakota, and network fellows in South Dakota, we're having to rethink, some of our summer traditions and summer protocols. Is it safe to gather? Is it safe? And then if not, what's available per individual and per family? So the second thought, and maybe a little bit related to that, is my uncle was recently telling a story on Facebook Live, and my uncle's maybe in his mid 60s right now, and he told a story of my great grandmother. My great grandmother's name was Eva Flying Earth, and she was a nurse. I'm not totally clear on whether or not she was a nurse during the 1918 pandemic, but the story, as he told it, was that our family was affected, and she was the sole survivor of our family. And it made me think that if not for her, I wouldn't be here.
Wow.
And something that she did, the resilience, the power that she held, made it possible for me to be sitting here talking with you, and that how will I also leave a legacy for my as an ancestor to the future generations, in which they can think back that hopefully, you know, that I'm not the sole survivor of our family, but that it's part of the narrative of who I am in connection to my community. And so I think there is some power and agency to be taken and to be gathered from our stories, that this is, though this is unprecedented in our lifetime, that our ancestors have gone through similar things, and have gone through pandemics and sicknesses and epidemics, and we're still here, right? We are.
I wanted to present that to you also from the standpoint that his framework is one that is quite focused on both and notion that in some respects, despite all that has happened, the use of history, historical strengths and narrative was very important in trying to make it through this particular pandemic. And we heard this over and over again from many of our grantees, that in some respects, how do you navigate both the discrimination and racism that Dr. Shim spoke about on a daily basis, but also in some respects, hold on to your traditions, your worldviews, and your healing strategies that actually help you to get through it. And the question is, how is it possible to do that when the larger services and systems don't appreciate not only that worldview, but are still dehumanizing in their ignorance, sometimes unintentional and sometimes quite blatant. You can see here is an image, I hope you can see, of our sort of campaign to get to the understanding of how COVID-19 might impact young people in particular. And in some respects, part of our work is not only how to message these notions, but take this information that we've gotten from our grantees. So the idea of hope, right, as a key aspect of this work is still very important. The other is, how do we find ways to disrupt dehumanization in policy practices? You can still see here, cash and food assistance, as has been said by my colleagues, is still a major sort of notion. I'm going to end. I had more to give, but I just want to say that you can look on the website to get more information about this, including podcasts where you can hear the voices of these leaders. And I'll end on the proverb: the lion story will never be known as long as the hunter is the one to tell it. If we are going to be more relevant in not only our interventions, but our research, we're going to have to think better about the measurement of the conditions of our people of color and communities, as well as their worldviews and practices. And I'll stop there.
Okay, thank you very much. I'm Lark Wong. I'm one of the leads on this webinar, and I want to thank Howard, Maggie, and Ruth for really compelling and informative presentations. You've clearly set a larger picture and a broad focus on what's happening in communities of color during this COVID pandemic. And we have a few minutes for questions. We have a lot of questions that have come in, and I'm not quite sure where to start with these questions, but I'd like to first start with Maggie. Several questions came in around what's causing PTSD in underprivileged children by parents. Is domestic violence involved, physical, mental abuse? And what's the role of balancing sending children back to school with the concerns around the COVID pandemic?
Yeah, let me start by saying that we tend to blame the victim rather than the other way around. So I want to start by saying that it would be a mistake to put the blame on the parents when actually you can see all the information I wanted to relay is how we are building parents that can't even cope because they're being left unemployed, they're not giving sick leave, they're overwhelmed with debt. They have housing insecurity because they're being evicted. So I think blaming the victim would be the worst case scenario. I think we should move the why weren't we, I think Brandon said something very important. Why weren't we going to those communities and supporting them, knowing that they were suffering so much, and helping those communities first, because they are the most vulnerable. I think the PTSD, to just respond, has to do with so many adverse events that kids are seeing now in their communities that are having to do with their environment and the conditions that they're seeing their parents have to deal with all the struggles. But I would hate to see blaming the victim.
I would just like to add on to that, because I just want to point out how easy it is, how easy it is for us to fall into that pattern. And this is definitely not in any way to say anything negative about the person asking the question, because I appreciate that the question was asked, but it points out how we have this tendency to, again, go to what Dr. Stevenson was talking about with this idea of what is wrong with you instead of what happened to you. So when we think about what's happening in these communities, it's much easier to say, oh, the parents must be, wrong or doing things wrong, or the parents must be harming their kids in some way, instead of thinking about, oh, perhaps redlining and the structural systems that have been set up have created neighborhoods that are unsafe, that are violent, and parents are forced to live in these neighborhoods with poor supports and poor ability to cope. And then their children are exposed to neighborhood violence, as Dr. Alegria pointed out in her presentation. And so all of this comes into play, and those are the reasons why we see these higher rates of PTSD. It's despite the best efforts, and honestly Herculean efforts, I think, by parents to try to protect their children and keep them safe. But they're in environments that are just incompatible with that.
Okay, thank you. Go ahead, Howard. Yes.
If I could also add that when we talk to folks in the communities, they are actually trying their best to teach their children about the larger history and where these kind of conditions came from, so that they don't swallow the Kool-Aid of that negative sort of perception that they're the problem.
Okay, thank you each for your responses. Another question really focuses on some of the broader factors that you all were talking about in terms of what are the social determinants of mental health and how do we look at that in this COVID environment. So the question is, what are large-scale community-based countermeasures can we do to address disparities in COVID care? This person has been leading a community collaborative of 26 organizations to address a devastating spike in her community of Hispanic COVID cases and resultant hospitalizations, looking for additional ideas for actions.
So I'm going to start saying that I think we have to work with the spatial divide that there is in communities of color and integrate resources into those communities in trying to disrupt. I have to say, I'm a believer of trying to make demands about the needs of these communities as the first thing, but we also need to bring powerful players to come to see what's happening in these communities and align themselves with what could be done and could be fast done. For example, we believe youth are, a catalyst, like Dr. Howard was saying, in trying to show them the importance of them becoming activists in trying to change their communities, but also talking to powerful figures about what's happening to them and how they need to address their needs too. So that to me would be the first one.
Thank you. Howard or Ruth?
I would say, one of the, again, looking historically, what you see in these very same communities is a history of divestment of resources, all resources. And so the question is, how are we going to change the minds of those who are creating policies to realize that we do privilege other communities by how much we give them and access, whether it's financial, whether it's, conditions of the parks and recreation. You could go across the gamut. The access to hospitals alone, you could argue, is one of those issues that we could do something about to make a difference. The question is, where can you track the history of divestment in these communities as one way to figure out what you can do? For example, our Philadelphia School District has been underfunded for years, and just recently, someone, the president of Penn gave $100 million to the school district. That is important in making a difference when we've known for decades that those schools vary differently in sort of, cost per student and resource per student compared to the ones in the suburbs.
Thank you.
And
yes, go ahead, Ruth.
I would love to add that, so what we're seeing, and I didn't get a chance to talk about this in the limited time we had, but also mentioned by Dr. Stevenson, is that there are oppressed communities that the function of oppression, or a type of oppression, is powerlessness. And that powerlessness comes from preventing people from having a voice, preventing people from expressing power, keeping people from methods of power. And so in these communities of color, you've seen a divestment, not only in all ways, but particularly in their ability to represent themselves and to prioritize their needs politically. And therefore, the work then becomes figuring out a way to prevent things like voter suppression in these communities, and to increase political representation so that the needs of the community can be prioritized in the policy making and in the decision making process. So building up the community's own power to be able to affect change is probably one of the ways that I think we would make some progress around improving COVID outcomes in these communities.
So much of this discussion has focused on social justice, racialized experiences, racialized violence. Want to go back to the earlier session on telehealth. This is kind of a leap I'm going to ask you to make. The question is, in terms of telehealth, how does that play out in creating better access in mental health issues for communities of color? What are the approaches? Does it work? Is it trusted? Is there a digital divide?
I can start off and just share my own personal clinical experience. So I've been doing telehealth with indigenous communities in Northern California for several years now. Those patients would come into our clinic. They would come into their clinics located in their settings, and they would have telehealth with me, the psychiatrist. Since the pandemic started, they cannot come into their clinics, and therefore they are not accessing telehealth services with the same frequency as before. So they made a pivot and tried to do telehealth services to people's homes. But what I found is those indigenous communities often lack bandwidth, often lack broadband capabilities to be able to do that. So there's been a massive drop off in access that I've seen. I've seen an increase in telephonic services. So I'm speaking to most patients on the telephone instead of through video capabilities anymore. And so with this rise, and this is data that was presented in the earlier session quite effectively, with this great, huge rise in telehealth, and Dr. Alegria pointed this out as well, you still see this widening gap of inequities around mental health. And so I think we have to be extremely careful about how we think about telehealth as a solution or a way to try to address some of the challenges that we're seeing here.
Yeah, we have two big projects that are being done by telehealth. And like Ruth said, what we're finding is not everyone has the ability to do telehealth, particularly because of the bandwidth. I think we're seeing, and then also some people don't want their faces to be seen, to be honest, because of fear that they will be tracked. So there's the distrust because of all the things that are happening to our communities of color. And then there's also the digital divide that I think will be there. I think we're doing better by trying to give them, for example, either phones or trying to get them notepads that they can then connect to us, and then we could have these sessions. But I think there is still a huge disparity in who has access to telehealth.
So we are at our time limit now. I want to just share one more comment from a participant, Beth, who says to all three of you, thank you so much for bringing hope into this conversation. It's important we remember there is hope for all of us to contribute to the reparation of the systems that are broken. Thank you very much. Your presentations were terrific. I'm going to turn it back over to Deidre.
Well, thank you, Lark. And many thanks again to all of our speakers today, Drs. Brendan Saloner, Joe Parks, Ruth Shim, Margarita Alegria, and Howard Stevenson for your outstanding presentations. You've given us an abundance of food for thought and helped us to imagine viable solutions to some of the most daunting public health challenges in human history. We owe a great debt of thanks to Forum co-chairs, Drs. Colleen Berry and Howard Goldman, to Workshop Planning Committee co-chair, Loc Huang, and the entire Workshop Planning Committee, and to Caitlin Friedman and Laureen Gregg and their phenomenal team at the National Academies. Now, most of all, we thank everyone who attended today. We sincerely hope that this program has given you information and inspiration that will enrich the work you do day to day, every day, to make life better for people at risk and living with mental health and substance use disorders. Next slide, please. An archived recording of today's webinar will be available on the NASEM website at the following link. Next slide, please. So we look forward to continuing this essential conversation and encourage you to join us for the third and final webinar in this virtual workshop to be held on Monday, December 14th from 1 o'clock to 2:30 p.m. Eastern Time. You may register for the webinar at the following link to the National Academy's website. Again, we thank you for joining us today. Until we meet again, we wish you safety, vibrant health, and peace.